When I first started this, I was just going to do the forefoot, and then I realized, there isn't enough for me in the forefoot. I could go into super detail or something, but let's call forefoot and midfoot. We'll still put our foot forward. So we're going to talk about both of these, and I'm going to look at, guess what? Normal anatomy and pathology. And I want to thank Jenny. She gave me some really nice cases for this lecture, so I appreciate that. Let's go on now with our outline. We'll start with the midfoot with some normal anatomy. You remember Chopard's joint, definitely the stepchild of Lisfranc, but you can see that is the kind of transverse tarsal joint, which means it's the calcaneocuboid and talocalcaneal navicular, a little more proximal to the more famous Lisfranc joint. And Lisfranc, as you know, is going to be essentially the tarsometatarsal joints. Again, there's going to be some overlap here. If you went to the ER session, you know I gave several foot cases. There'll be some overlap, but you remember that that second TMT joint is recessed. And so that forms the kind of keystone of the midfoot arch, and it's extremely important in terms of midfoot stability and avoiding early onset osteoarthritis. One thing I was less familiar with is columns. Sometimes you might hear clinicians or surgeons talking about columns. The lateral column is really the fourth and fifth rays. That's the most mobile, and it includes the cuboid. And then the medial column is pretty much the first ray from that medial cuneiform all the way down the first metatarsal. And then the middle column, as you might guess, is the most rigid, the second and third. And you notice a lot of times we'll see pretty severe arthritis in those second and third TMT joints, and it may be because of this situation where that is the most rigid part. That's also where our Lisfranc interval lives. All right, so midfoot ligaments. We'll start with that. You have longitudinal tarsometatarsal ligaments, both dorsal and plantar. You also have intermetatarsal ligaments from the second through the fifth, but as you know, we don't have one between the first and second. Instead, we've got the famous Lisfranc ligament between the medial cuneiform and the base of the second metatarsal. This is from the literature where you can see that people talk about three areas. They call it the ACL of the foot because it's so important for stability. The three bands are the dorsal, the interosseous shown in blue, and then the plantar. And as I mentioned yesterday, nice article from now a while ago, but they went to surgery and they found that injury to those plantar components were very highly correlated with true midfoot instability. So it's something to keep an eye on. If we look, there's the kind of interosseous, if you will, and then those plantar fibers that are so important go to the second and third metatarsals. Now, radiography, you remember you want the weight-bearing view, right? Because that's kind of a dynamic stress. Here you can see on the AP view, the medial cuneiform should line up perfectly with the with the first metatarsal, and then the middle cuneiform with the second. As we go to the oblique view, the third should line up with the cuneiform and the fourth with the cuboid. So that's our normal anatomy. Now, in terms of measurements, if you want to measure, this should be no more than 2 millimeters where Lisfranc ligament lives. And there should be less than 1 millimeter side-to-side difference if you happen to do weight-bearing AP views there. So on MR, I like the long axis view here. We're starting to come into the inner osseous point, part of the ligament. You can see it coursing from that medial cuneiform over to the base of the second. And then as we go more plantar, we can see here going to the second, and we're catching the edge of the one going over to the third. Looking in the short axis plane, you can see as we come through some of the plantar fibers coming off the medial cuneiform. There's the interosseous coming across, and we can just follow those. Now, in terms of midfoot tendons, we got a lot of action here, but the posterior tibial has multiple insertions, and I'll show you a case of that as well as the normal anatomy. And then the flexor digitorum longus right behind that, and the flexor hallucis. All right, as we follow these cross at that knot of Henry, or master knot. So here, posterior tibial, digitorum, flexor hallucis longus, and as we come down, we can see that those two are really, yes, they do cross at the knot of Henry, but notice here we leave the navicular behind and all of these, and sometimes I'll ask the resident, okay, what's this tendon? Because it emphasizes how far these go. And here go the hallucis and digitorum. But these have multiple insertions in the midfoot. Now, in terms of the peroneus tendons, I think we're pretty familiar with these, but as we look, you can see the brevis usually lies in front of or medial to the longus. And then as we come distally, all right, you've got the superior peroneal retinaculum that held them behind the fibula, the inferior retinaculum where it hugs the calcaneus. The longus then shoots underneath the cuboid across the foot to the, it shows going to the cuneiform, but when I try to follow this, it almost always just goes to the metatarsal. Now, if we look at this on the, just happen to catch a long axis view where you can see it coming through what I call the cuboid tunnel and then coming down to that base of the first. Coming across on the short axis, I can follow that all the way over to its attachment. We know the brevis comes into the fifth, but there are two other things I want to highlight there. One is this weird peroneus tertius. The cordis, peroneus cordis, is the accessory muscle behind the fibula. Whoever came up with peroneus tertius, I don't know, maybe because it went to the fifth metatarsal. But if you look, you'll see this. I think in my years, I've seen maybe one abnormality along that. But keep an eye out on that lateral band of the plantar fascia. That comes in right below the peroneus brevis, and I'll show you a case of that shortly. All right, so we've got brevis in yellow, longus in red. We're coming down, and notice, don't forget that lateral band. The central band will go all the way out to the toes, but this lateral band will stop at the fifth. So following this down, you can see the longus here shooting under the cuboid, and then we follow the brevis coming in with the lateral band right onto the fifth. Uh-oh, here comes peroneus tertius. Don't worry about it. All right. All right, let's talk about midfoot pathology. Clearly, probably the most common thing we see is going to be neuropathic arthropathy in the tarsal-metatarsal joints. But there are a lot of other things, as we know, with stress injuries and trauma. Stress injuries are usually more than one bone, but we talked yesterday about this. This is kind of unusual, the cuboid and so on. We love looking at the metatarsals for stress injuries. I talked yesterday about the high-risk stress fractures, the navicular and the proximal fifth, as well as the hallux sesamoid. So let's take a look. The navicular, who's affected? People who jump and run, and this is an 18-year-old hurdler who had a sudden onset of pain in both feet during practice. Might be a little hard to see, but she shattered both of her navicular at the same time. What's mildly interesting about this one to me is that I was doing a procedure on a patient, and we were talking about radiology, and she said, my daughter's really interested in that. She's in medical school at Eastern Virginia, or could she come and shadow you? I said, of course, she can come. First thing I meet her, she said, yeah, I saw your name on my report. I said, what? And she said, no, I'm the one with the bilateral navicular fractures. And I was like, wow, you're in my lecture. She got a kick out of that. But she's doing fine. She's walking. I don't know if she's hurdling anymore. But it was just like, what a small world. All right. The problem with this is there's so much overlap here. It is very hard to see these things, so you want to know where to look. It's typically in the central third. Okay, you remember this is where the main force comes down through that second TMT joint, and it's aimed right at the middle of the navicular. This is a beautiful article from Skeletal Radiology, 2017, where they also showed this is a relative watershed between the dorsalis pedis and the posterior tibia. So it's also relatively hypovascular. This is what we're looking for. Okay, and it is tough. All right, so on radiographs, we often just don't see anything, but if you know where to look, maybe you can pick it up. I'm not even going to show you that because you couldn't see it very well. CT, and our surgeons sometimes, if we have an MR that shows a bunch of edema and we really can't tell if there's a fracture line, will ask us to do a CT because to him, if he can see a fracture line, he's thinking, and especially in an athlete, thinking much more about doing something surgically. But here on CT, obviously, we can see things very well for that. These tend to be in that sagittal orientation in the mid-navicular. MRI, we're going to see the marrow edema and then look for that fracture line as well. So here we have college football lineman. This is one I showed yesterday. You can see middle third of the navicular. Thankfully, our fellow picked that one up. And then here you can see on the MR that, in this case, a little bit more oblique, but in the central part of the navicular. This patient, due to different factors, went ahead and they did internal fixation of that. All right, now, what about this little os supranaviculare? We always kind of maybe mention it, or maybe an avulsion fracture, but there was a cool article I came across, and If you look on this 3D CT, you can see the ossicle, and there's always this little notch in the mid-navicular, and this article suggested maybe this creates a stress riser, because look where all the force is coming to. So they had this, 83, how many of you were even born then, okay? But some of us were in medical school, Walter, okay? All right. I haven't seen Walter since 1983, exactly. I'm sure you read this article. But they had 23, huge study, but what they found was almost a quarter of those had an accessory ossicle, and guess what? We had a cross-country runner come in with one of these, and check it out. Maybe there's something to it. But like every other accessory ossicle, you see thousands before you ever see it like this. All right, shaft metatarsal, those are easy, relatively easy, but the fifth, why is that high risk? That's kind of crazy. All right, well, who's affected? Guess what? Everybody. Cavus deformity sometimes puts extra stress there, but it's in the proximal shaft. And why are these high risk? Because they're in zone 3, which means this is the hypovascular area. Sorry, this is very poor blood supply. So they're weaker there, they get delayed and non-union. So here, this is where they will sometimes go ahead, and if conservative non-weight bearing doesn't help, they'll put a screw in. And here you can see college football, felt a pop. You can tell it doesn't really look like an acute fracture, but he probably had an acute injury on top of working on a stress fracture. So they did this, and this helps them get back into the sport faster. One of our surgeons thinks that this may actually cause more problems over time, but we see this quite commonly. So here's one of our lacrosse players, same exact place. This is where these stress fractures occur. And this was in January, got his screw in January. All right, a whole year later, in April, other foot. So there you go. All right. Metatarsal head, Freiberg's infraction, common in the second, can occur in the third, and so forth. Early on, we may just see marrow edema, but if you see this, guess what they have? That little subchondral fracture. And you remember I mentioned that this morning with the the femoral condyle and so on. This seems to be a common denominator, distal clavicle and so forth. So it's probably, and here we have a diabetic 51-year-old pain in the forefoot. You can see that. As we look on the sagittal, once again, a beautiful subchondral fracture there. This will then usually go on to collapse, and you get the flattening. Just, one more time, just to reemphasize that. But this, just like the fracture in the knee where we saw that collapse, these will typically end up with a flattened metatarsal head, but it can be quite painful at that stage. All right. Lisfranc ligaments, easy to miss, but not on this one, right? So these are the high energy ones. They have a lot of fractures, MVA, falling off a ladder, all of that. But these aren't ones you're going to miss. It's these low energy ones that we see in athletes, and maybe somebody just twists their foot and so forth. Classically, it's supposed to be in this position. They say that, classically you get a weight on the back of the foot if a player falls on it or something. I've seen more where people just twist their foot with their body weight and they end up doing this. So it affects that, typically that second TMT, and it's a challenging diagnosis. This one's easy, but if we miss it, as in this case, they'll come back with this kind of midfoot arthropathy due to the instability. So it's really high morbidity with this. All right, so staging. Well, if you measure here, they say this is the staging. So for those into staging, you can do that. But the question for the surgeon is this unstable or not? So we get weight-bearing views. Well, let's take a look. We're going to look for the flex sign. All right, let's take a look at this one. All right, if we mag that up, you're looking for this little, now this alignment doesn't look that bad to me, but watch for that little thing because it's often the tip of the iceberg. Here's the same patient on MR. Hello. All right, so massive injury with just that little fleck. MR imaging tend to look in the long and short axis. You can look directly at the major parts of the ligament and just see, as one of our women's basketball players, high-grade tear of that interosseous portion. Here's one of our quarterbacks. Came in with a midfoot injury. Just looking at this, there's something bad. And as we come through where we should be seeing the interosseous part, there's just nothing. Look on the short axis there, gone. Even the plantar fibers here are not good. Okay, so big time Lisfranc injury for him. All right. One thing I wasn't aware of until recently, I should have been, but I wasn't, is this proximal extension. There's a nice article in 2019 talking about the surgical implications of this, because I'm always focused down here. But I've learned we need to watch, because the injury can extend, and they call this proximal extension of the Liz Frank injury. And so you have to look at the cuneiforms. This is from their article. That one we're not going to miss, but it's something that can affect surgical planning, all right? If there's a solitary Liz Frank injury, they're just going to try and restabilize kind of this area. This is one of our football players hit and caught his ankle. He had some tenderness, as we would expect in this region, but the plain film really didn't look that bad. But as we come here, you can see if we follow the major Liz Frank kind of interosseous there, it's gone. But we have a lot of bone marrow edema in the midfoot. And then you start looking in this intercuneiform area, and you should see some nice little intercuneiform ligaments there. So this is one we should alert the surgeon to the fact that this looks like a more proximal injury. And in fact, this patient ended up with not only repair here, but also here. All right. Couple of interesting cases. This is a football player, midfoot pain, got to be a Liz Frank injury, right? Well, Liz Frank actually looked good. This was just a bone injury of the second metatarsal. It's kind of weird. But the good news was the Liz Frank was fine. 11-year-old, 2 recent injuries, tender right there. Guess what? Liz Frank looked great, but she had a little physeal kind of injury in her first metatarsal. So kind of show and tell cases, but not everything that kind of smells like a Liz Frank is a Liz Frank. So take-home lessons. Number one, it's an important clinical diagnosis. If we miss it, they're going to get osteoarthritis. Don't forget the proximal variants. And remember, weight-bearing films are critical for looking at an offset in that region. All right. CT is good for picking up the fractures if you have any question, and then MR you can directly visualize. Now, tendon pathology in the midfoot can mimic other pathology, and this is a 21-year-old runner, lateral midfoot pain, got to be a 5th metatarsal stress fracture. Well, as you look, it was really more of perineal tenosynovitis on this. The bones were fine. Here's another one. Guess what? Another runner, lateral midfoot pain, must be 5th metatarsal. Let's take a look. Here comes peroneus brevis in on the sagittal. Not too much on the T1, but we go to T2 and fat set, and you notice a lot of edema around here. Very hard to kind of sort out because of volume averaging, but let's look on the short axis now. Got our peroneal tendons here, but where is the abnormality? Here comes peroneus brevis. Looks pretty good at that level. But watch that plantar fascia. Seen this a couple of times where this mimics either a peroneus brevis injury or stress fracture in the bone, and this was in fact a partial tear of the lateral band of the plantar fascia. All right, so here you have a bipartite os perineum. Don't have it on the T1 because it's so dark. And this is a long axis view showing a lot of edema there. Here it is on the fat set T2 or STIR. And then here it is again. And this is that painful os perineum syndrome or POPS syndrome. Okay, so that can be a cause for midfoot pain. I've seen this probably a handful of times, and many people have probably seen this as well, but that is the os perineum, right? Where should that live? Under the calcaneocuboid joint, right? And so looking here, that was the MR. And so this is kind of a nice sign of a peroneus longus rupture if it's retracted like that. This one, there's the ossicle, not much home beyond that. So in this case, you can see this. It should be here, but it's retracted to there. Now this is our lacrosse player, again, another one. Midfoot injury, thought about Liz Frank, but that looked okay. All right, there were a couple of things that were just kind of bizarre. Here comes the posterior tibial tendon. Here comes part of the posterior tibial tendon, and we can follow those down. And pretty much everywhere that should have come in for a landing on these midfoot bones had a lot of edema and some ill definition of those tendon fibers. And so this is my guess. I mean, look at this. I mean, couldn't see a fracture line and so on, but he had a lot of injury right along where these tendons inserted in some of the bones, but mostly along the tendons. I'm sure some of these were contusions and so forth, but this is probably what they would clinically just say, oh, it's a midfoot sprain, whatever. But notice also his tibialis anterior coming in had a lot of fluid and well as probably some irritation there as well. So anyway, not everything Liz Frank is Liz Frank. Now let's move to the forefoot. Interesting. You can use this at the next cocktail party or whatever, but in a normal gait, about 60% of your body weight is felt at the first MTP sesamoid. You go do anything, and it'll go up to about 3 times your body weight. Some of us, that's more than others. Running jump. Hello, do not jump, all right, because 8 times your body weight on that little joint. And stability, the bone's not very stable by themselves, but this is where the capsule, ligaments, and tendons come in to stabilize that first MTP joint. So let's look at the anatomy. Thank you, Jenny, for this. We've got the first MTP sesamoid complex. All right, so we've got our medial lateral sesamoids. Here you can see the sesamoidal kind of metatarsal, almost like collateral ligaments, if you will, here. Then we've got the intersesamoidal ligament holding those together. And then most importantly, for these types of injuries, we have the sesamoidal phalangeal ligaments. So these are going to go distally from the sesamoid there. All right, and this is where it tends to fail. And so it's a very important part of the plantar plate, if you will. All right, beautiful high-resolution MR, first MTP joint, blah, 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 from 2020 in radiographics, if you'd like more. All right, if we look at the kind of short axis view of the forefoot, we've got a deep transverse metatarsal ligament. The bursa, intermetatarsal bursa, tends to lie above that. Then we've got that, and then we've got the neurovascular bundle, which is where we're going to be looking for the Morton's neuroma and so on, below that at the level of the metatarsals. So when I'm looking at that level, main thing I'm looking for is this interdigitating fat. Because if we have a bursitis, if we have a Morton neuroma down here, usually, as has been pointed out before, that T1 is so important for picking out those types of things. So I call this kind of the suspension bridge of the intermetatarsal fat there. All right, so sesamoid pathology, lots of things. All right, probably the most common is going to be just degen with hallux valgus and so on. But you can have osteonecrosis, stress fractures, and so on. Guess what? It looks like everything else. So you're going to see low T1, bright T2. Can I tell the difference here? If I can see a fracture line, maybe, and so on, but sometimes just have to give a differential. Here we have a 17-year-old started a walking program. You can see the abnormal signal on T1 and the fat-saturated T2. Stress, osteonecrosis, I don't know, probably stress since you just started a walking program. But here's another one, runner with forefoot pain. Notice this is not only jet black on T1, but it's also fragmented. So you can see it there and there and there. And this, I would say, highly suspicious for osteonecrosis with fragmentation, given that super low density, or excuse me, intensity on the T1 and the T2. All right, so plantar plate injury, the turf toe, all right? It's usually in this position where it stresses that first MTP joint and those supporting structures. All right, and it's a hyperextension injury. And those poor little ligaments are trying to hold on for dear life, and we get a rupture typically of that sesamoidal phalangeal ligament, but it can involve all the other structures as well. It's those tensile forces pulling that joint apart. All right, so yes, I don't know, have anybody here used a stress view of your... No, okay. Well, just for, I guess, historic sake or whatever, you can actually do this kind of stress view. And if you notice, you compare the other foot. So here is the unaffected side, and as they pull the toe up, this kind of comes forward underneath the metatarsal head. Here, they pull the toe up, and it stays back there. Cool, okay. We don't typically do that, but there's the rupture of that plantar plate. Was that your case, Jenny? I think so. All right, so ultrasound. All right, now, several of you do this, but you can do a dynamic assessment of this. And so here you can see this rupture here, ultrasound. You can see the sesamoid. You can see interruption in this region, mainly because there's an arrow there. All right, and so beautiful case there. And then MR, we're going to look at all of those structures, okay? 20-year-old football player with turf toe injury. Let's take a look. You can see interruption of that sesamoidal phalangeal ligament there. This poor guy was a real star recruit, and he came in first spring practice that he could practice with them. He injured his foot. So didn't really see too much on the radiograph, but got the MR. Take a look at this. This poor guy is 18 years old. Coming into the first sesamoidal phalangeal ligament, gone. All right, coming across, gone. Both of his sesamoidal phalangeal ligaments. We look on the short axis view, you can see a lot of muscle injury as we come down. That metatarsal sesamoidal ligament gone on the lateral side there. Inner sesamoidal ligament gone. He just exploded his plantar plate in his first spring training. All right, college football turf toe injury. Again, these all look alike, right? The interesting thing here was, we know about this, but what's going on out here? He's got marrow edema in all of his metatarsals, second through fourth. Well, he's offloading that. And so he was developing stress reactions in his metatarsals because he was trying to protect that injured first MTP joint. Boy, what do we do with this? Not all acute injuries involve the plantar plate. This is a great case. How you do this, she dropped a barbell on the back of her foot with the toe hyperextended, just like I showed you the classic mechanism for a plantar plate, but this time it was a barbell. So you can see we've got a lot of edema in that medial, and sometimes I have a hard time when they have a bipartite telling, you use the plain film, is it a fracture or not? But sometimes I've had a case or two where it looks like they kind of broke the synchondrosis between those. And so this one didn't look exceptionally wide, but she certainly has a lot of bone marrow edema within that. But the plantar plate was fine. So careful in the weight room. All right. Morton's neuroma, check it out. So many patients have this. Remember, it's not a true neuroma. It's fibrosis around the digital nerve. Guess what? The larger ones are more often symptomatic, but there are a lot of us walking around with this kind of fibrosis with no symptoms. So clinically correlate, right? Anyway, how many of you inject these under ultrasound? We do a ton of them. And the thing is, we may or may not see one, and it's just like kind of saturation bombing. We're just going in and hitting this whole area. But on ultrasound, we can use the maneuvers to try and see if we can see this. On MR, it'll be low on T1, and the confounding thing is that the actual area of fibrosis will often be low on T2, and then will often light up with gadolinium. Here's another one where you can see, again, I'm looking for that fat in the web space or in a metatarsal. There it is. Even if I don't look at the others, that shouldn't be there. All right. The other thing that can possibly be there is going to be intermetatarsal bursitis. What do we do with this? All the time we see this. There was an article that said if it's more than 3 millimeters transverse in the area, call it a bursitis. I just say there's small amounts of fluid there. If it's distended, I'll say it's distended. Here, typical, but this one's distended. That was the largest one I've ever seen, so we'll call that a bursitis. And then these pressure lesions were something that can really be confounding. One of my partners many years ago actually biopsied one of these because it looked so mass-like. It's often under these pressure points like first and fifth metatarsal, probably the most common area that we see them, but they also under the calcaneus. And they can be, if you've got an elongated, remember this, Morton's foot? Not really. But a long, thickened second metatarsal, you'll get more pressure under here, so you might see it there. But we're thinking about pressure points, and this is why these things can get biopsied. You look on T1, that thing really looks mass-like, but it's really fibrotic tissue in the plantar fat, and if it's under a pressure point, I just say there's a pressure lesion. T2, it's not very exciting because there's a lot of fibrosis there. Here was an interesting one. It looks much more circumscribed than normal. That's T2. And that's gadolinium, and this becomes an adventitial bursa at times where it just cystifies centrally. All right, that's about it. Thank you. Thank you very much.